Hello everybody. Today we discuss a very important topic in critical care medicine, that is acute pancreatitis. This is important not only just clinical point of view but also in your everyday practice, where you will frequently encounter a case of pancreatitis, and the treatment as such may appear simple, but it is associated with huge morbidity and mortality. So we will be dealing under definition, etiologies, cause in pancreatitis, grades and prognostications, investigations, goals of management, surgical intervention and the management of complications. Please remember, this is a very important topic as it is a very frequent question which is seen in any of the DM exams or DRND exams or even in your IDCCM exams. So let's begin with definition. What is acute pancreatitis? It is an inflammatory condition of the pancreas which is most commonly, we believe, either caused due to gallstones or excessive use of alcohol. So what does IAP or APA, that is International Association of Pancreatology or American Pancreatology Association, define pancreatitis as? It defines as pancreatitis as basic fulfillment of two criteria. As we all know, patient comes with a pain abdomen, and whenever patient comes with a pain abdomen, we first think of pancreatitis, especially in the background history of alcoholism, and we try to do amylase and lipase, wherein if we find the serum amylase or lipase level more than 3 times the upper limit, then if we happen to do an imaging either in the form of ultrasound or CT or MRI. So the IAP or APA defines as 2 of the 3 criteria should be fulfilled, that is either the upper abdominal pain with an increased amylase or lipase or a radiological imaging which is showing us that there is an inflammation of the pancreas. And this is a grade 1B recommendation which has got a strong agreement. So etiology. Etiology you all must be very clearly knowing. 2 main important etiologies, gallstone pancreatitis, alcoholic pancreatitis. Both of them more or less equal. Some believe that in the west it is more of alcoholic pancreatitis followed by gallstone, and in the east it is more of gallstone pancreatitis followed by alcohol. But almost 30 to 40% of the times we do not have an etiology and we term it as idiopathic pancreatitis. Other than that, family history of pancreatitis or usage of drugs like azathioprine, cyclosporin, valproic acid, infective pancreatitis, hypertriglyceridemia, or any history of pancreatic tumors or corticosteroid use, sulfa abuse, drugs or hepatitis A, B infection, Coxsackie infection, mumps virus infection, or a post-ERCP pancreatitis, traumatic pancreatitis also do form other common etiologies. This is very important, especially when we approach for a treatment, because the source control also forms an important aspect of treatment here, and as well as a theory point of view. Grading and severity. So as we already discussed that pancreatitis is associated with high mortality and morbidity. So grading of a pancreatitis at the admission as well as 48 hours post admission becomes very crucial. So we have 2 types of classification here, revised Atlanta classification and determinant based classification, which divides pancreatitis into mild, moderate, severe, whereas in determinant based classification we have an extra criteria which is a critical. So mild, as we know, it's a mild pancreatitis wherein patient presents with to us with an abdominal pain with an increase in enzymes, that is amylase or lipase, but there are no organ failure, no local complications, no systemic complications, and typically the pain and enzyme levels resolve within the first week. So both for RAC and DBC it is the same. Whereas in moderate there is a transient organic failure. Now what do you mean by transient organic failure? There is an organic failure either in the form of decreased P/F ratio in an ABG which is causing some acute lung injury, or there is a small amount of acute kidney injury, or you have a small amount of hypotension. But this is transient, that is this organ failure usually more or less reverts back in 48 hours. The same thing is for determinant based classification, wherein they mention that there is some amount of sterile pancreatic or peripancreatic complication, that is a local complication with a transient organic failure. Whereas in severe classification we have not only a local complication but we even have a persistent organ failure going beyond 48 hours. When we come to determinant based classification, there is one more extra criteria, that is critical, in which there is definitely an infectious pancreatic or peripancreatic complication, that is there is a pancreatic complication which is most probably assumed to be infectious followed by a persistent organ failure. So why do we need to remember all these things is because this is very important, especially in Viva as well as in the theory answer.